let's keep moving. This is, we're going to head into alignment. And what I want you to understand is that I like to call it the linchpin, because really it does pull together all of these systems and opportunities and inputs that we've been talking about. And I want to start here with this particular study. This is a study that they did on children, and I think it's so demonstrative of what we've been talking about. They took typically developing children, so neurologically typical kids, and they asked them to get into that position that kids with cerebral palsy tend to walk in, that kind of crouched position. And they had them stand in that position, and they measured muscular recruitment. And what they found was that these kids were actually, the neurologically typical kids were demonstrating a similar recruitment pattern in a balance challenge that kids who have cerebral palsy demonstrate. Similar recruitment pattern. And so they sort of, that was a kind of a surprising outcome, because they had typically attributed that recruitment pattern to the children's neurological damage. So now this was telling them that the position itself was contributing to the faulty recruitment pattern that they saw in children with cerebral palsy. So that was pretty demonstrative on both sides. It gives us information regarding the contribution of alignment to recruitment of musculature, but it also helped them understand that there was more going on than just the neurological damage, and then hopefully an area where they might be able to make some improvement. There was a similar study done where they found the same thing in gait. They actually had the children walk in that crouched position and found a similar recruitment pattern for the neurologically typical children, when similar patterns to the children with cerebral palsy. Okay, so that's just, again, kind of just to get our wheels moving again on all the stuff that we talked about in module 1. And so let's sort of start with a reminder of all the areas that alignment impacts. Okay, we're talking about muscular recruitment, and the word I love to use now is availability. It optimizes the availability of the muscles that we're trying to recruit. Okay, it's that mid-range optimization idea. And then when we change head position, okay, and the head, guess what the head sits on? The rib cage. Okay, so when we change that head position, when we're changing the rib cage, we're changing vestibular input. And this, remember how sensitive the vestibular system is? This is a really big change, and your patients will feel it, and you will feel it when we go through this material. We change your cranial nerves. We change proprioception. If I'm changing my position from here to here, I just changed where my weight was going through all sorts of joints. All of my vertebral joints, my hip joints, my knee joints, by changing that pressure, I guess is one way to think of it, by changing that input into the joint, I'm changing the information that's going up into the brain simply by doing a position change. Same thing with visual input. We've already seen the impact that this has on breathing patterns, and joint centration we already talked about. So these are all inputs for the brain to evaluate for all sorts of things, but one of the major things that we like to talk about in adult care is pain. And so as we change all of these inputs, it gives the brain new information in order to evaluate threat, to create that protective pain output. That's the stuff we alluded to in part 1, but there's other things going on here. Okay, if we change breathing, we change ANS activation. Okay, when we change proprioception, we change joint, the way that pressure, impact, all sorts of things are going through the joint. If we change muscular recruitment around a joint, we change support. There's a lot of things that alignment impacts that has more to do with I hope that just sort of increases our understanding of all the things we're doing by changing alignment. Okay, and so we get this. We've already talked about this. Alignment can enhance or diminish the components of that anticipatory central stability system that we've been talking about, and the reactive components as well. We know that if you do glute work with your bum tucked under, you're not going to get much glute work, right? That's not a crazy concept for me to tell you, right? And we get this with muscle lengthening concepts. So if I did have a patient who was in an anterior tilt, we might say some of the issues that they're presenting with is because what particular muscle group is tight. And so hopefully you're thinking psoas, that's the hip flexors, is something we always think is tight in someone who's anteriorly tilted. What about if they're posteriorly tilted? If they are tucked under, then we think their hamstrings are tight, right? So the idea that alignment changes both the availability of a muscle, the ability for us to strengthen it. We're talking about form when it comes to exercise, right? That's not crazy talk for us, okay? So this is our accepted terminology. So when we have a conversation about alignment, this is the accepted terminology that we have: hyperlordosis, anterior tilt; hypolordosis, posterior tilt; neutral pelvis and lumbar spine. So really what we're talking about when we communicate that way is from here to here, right? So our thoughts all think about here because those are the words that we're using. But unfortunately that does not communicate about the position or the forces that are being imposed by the upper quarter onto this circumstance, okay? And so it's important for us as we start to think this through, what are we looking at when we're looking at alignment? So we are going to take a little pop quiz here, and I want you to name this alignment. And we're going to use our accepted terminology because that's all we have in our communications. Let's say this woman is either anterior tilt, hyperlordotic; posterior tilt, hypolordotic; or is she in neutral alignment? Okay, so I just want you to take a moment to think about that. Give you a sec. And name it and kind of create a defense. Okay, what are your arguments for your particular position? Okay. Now, obviously we're doing this online, so we can't have a conversation about this, but if I was doing this live and you were attending a live course with me, I do this exact same thing. And then I ask people to raise hands. And when we go through the who thinks it's anterior tilt, who thinks it's posterior tilt, who thinks it's neutral, I get therapists in the room in each category and fitness folk, okay? That means that there is no great, we don't understand, we shouldn't have that, is what I guess I'm trying to say. Everyone should have the exact same answer. We should be able to look at this woman and very quickly be able to assess what is going on with her alignment. But we unfortunately, like we kind of saw in the module 1 information, we don't even have the same terminology when it comes to talking about alignment. And so it's critical that we really, this is why we're going to try to piece this together, because so I'm not going to give you the answer except for to show you this is how she actually likes to stand. Okay, this is her natural posture. Okay, so this is actually her attempt at creating neutral. Looks pretty good to me. Okay, remember, neutral is a range, and we want to kind of think of it that way. We'll keep talking about that as we go, but this is what she really likes to do. So now, how about now? Let's think about this. What do you see in this picture? What do you think is going on? Okay, is she hyperlordotic, anterior tilt, hypolordotic, posterior tilt, or is she neutral? Again, I'll give you a second to think about that. Okay, what I usually get live is that now everyone says that she's anteriorly tilted hyperlordotic. Okay, and the argument is that she looks really lordotic, right? And so let me just kind of talk you through this. If you drew on the front a pregnant belly here, she would actually look just like the woman in the red shirted pregnant woman in module 1. Okay, so she has, where's my cursor? There it is. So really what you're seeing here is the rib cage. This is the rib cage shifted way back, okay, and tipped up. And what I want you to notice here is this is a pretty flat top of the buttock, okay, and and that goes up into a flattened lumbar lordosis. Or lack thereof. It's difficult to see because of the elbow. This was snapped without her knowledge. So I was trying to capture a moment for her. But what you're seeing here is what is really typical. This is the pregnant posture that we talked about in module 1. Now, without babies inside, she's maintained that position in her day-to-day movements, in her exercise. She goes to the gym 3 times a week and exercises like this and has only just continued to reinforce this position and this posture over and over again, which has reduced her access to that central stability system that could really address some of the issues she was experiencing. Okay, so I want you just to really take note of this. We cannot have a position of the pelvis like this. The lumbar lordosis and the pelvis, those are coupled motions. So anytime you're going to see a sort of a flattened posture in the bum, you're not using your glutes well, and the bum is generally tucked under. So what I like to call this posture is mixed. Okay, which was not one of your options, and I wish I had been more creative when I started trying to describe it. But the reason that I talk about it like that is because it's mixed up. It does not fit into our categories because the lordosis is not hyperlordotic. She's actually hypolordotic, posteriorly tilted, but that rib cage position has just tricked our eyes for years. Okay, and this might help you start to think through, like, why? I mean, I'm going to raise my hand first. How many of you have spent entire sessions on trying to find a way to stretch someone's psoas that looks like this?